Welcome to my podcast. Today I'm going to talk about another case that you can come across in the medical setting or in the ER. So after you introduce yourself, always will read patient, check the patient name and date of birth. The patient will present with acute, painful, swelled ears, with acute tenderness. And he will mention that I'm having this for the last couple of weeks or so. I'm just recently noticing pain in my hands, my finger. I feel my chest is kind of tight. Otherwise, the patient is well, non-smoker, is not taking any red kill medication, no allergy. There is no past exposure to any occupational risk of note, and his observation quite normal. However, when you examine him and ask him if he has any thought of the issue, he will say none. You will notice that there is firm erythematous nodular swelling affecting both ear with the pinna, and it's quite tender and warm to touch. And his hand, there is also generalized bilateral metacarpal and pharyngeal joint tenderness. When you examine his cardiovascular, it's unremarkable, and you start to wonder what you need to do next. You will send for certain blood investigation, and his full blood count was normal, urine electrolyte was normal, seroactive protein, an inflammatory marker, all are normal. Chest X-ray was normal. So then you might think about further investigation, like, for instance, to rule out why he has this tightness of the chest. Possibly after you ask his seniors, might send for chest X-ray, which shows ground glass ossification of multiple baromedular nodule and bilateral mediastinal lymphoadenopathy. So this will give you the thinking what might be the reason for this presentation. And in the UK, it's quite common to have this differential that I'm going to talk about. So basically, when you have those presentation, you will start to think about certain differential. So I said that there is bilateral ear swelling, it's tender, quite painful, associated with the arms, in the hands mostly. So this will keep you thinking about relapsing polychondritis. And the patient has tightness of the chest, so you will think about tuberculosis, occupational work thing, but however he denied. We could think of asbestos, we could think of silicosis, and also tuberculosis, as I mentioned. And the other thing is sarcoidosis. The only feature here which point out to the diagnosis is the bilateral hilar lymphoadenopathy, which align with sarcoidosis. We know sarcoidosis, it's kind of common in the UK. It's inflammatory multi-systematic disease characterized by formation of non-caseating granule or granuloma in the affected organ. And as I mentioned, it can affect any part of the body. It can affect eye, can affect face, can affect lymph node, can affect any organ in the body, heart, liver, spleen, any part, lung, skin, as we know, cartilage joint, any part, basically. And the manifestation can be acute or subacute or chronic. So when it comes to the lung, which is the predominant place, it can be manifested as cough, shortness of breath, maybe tightness or chest pain. And of course, interthoracic lymphoadenopathy can present in up to 90% of the affected patient. So that's one of the things that we need to think of and look for. Cutaneous manifestation can be in different variety of manifestation, can be erythema nodosum, can be papular facial rash, can be lupus porno, nodular infiltration, multiple nodular infiltration. Extra pulmonary can be neuropathy, myopathy, arthritis, myopathy, polyuria. And the risk factor, basically, it can be genetic, as it has been notable in human this HLA, which is the element of genetic, and can be also triggered by the environment, like mold exposure, insecticide, or if working in agriculture, occupational. However, the blood test is not mostly diagnostic, and rarely can find something like cytopenia or non-specific inflammatory marker increased. But in that situation can be diagnosis exclusion. We know that angiotensin converting enzyme can be raised, and also the calcium level, which can support the diagnosis of sarcoidosis, but it's not specific after all. Chest X-ray can be the hallmark diagnosis, as we know, and because it's characterized by bilateral hilar lymphadenopathy. And also, if you be more specific, can send for CT scan, which will illustrate the bilateral hilar lymphadenopathy with the finding of micronodular pattern and perilymphatic pattern, which is highly specific for sarcoidosis. And of course, histopathologically, the biopsy will show non-caseating granuloma, which is composed of collection of large epithelioid histiocyte with multinucleated giant cells. So in this situation, once you come up to a diagnosis, you need to discuss with the patient how we can move forward, explain the situation and the long-term implication and the management ways. So we know that the first line of treatment is oral corticosteroid, or corticoid, and which we start with the treatment for a minimum at least 12 months. Also, in a situation we need whereby to stop the steroid and start the the steroid sparing drugs like methotrexate or azathioprine or JAK inhibitor, and like infliximab. In also in those cases whereby they are steroid or methotrexate resistant cases. We know that there's the condition of called relapsing polychondritis, which is one of the differential, and this affects mostly air, nose, respiratory tract, and the lungs as the rare thing to be affected. So that's one of the differential that we need to think of. Another thing that I mentioned early on is tuberculosis, which usually will manifest as unilateral rather than bilateral, as the case in sarcoidosis. And the silicosis, the silica, it will produce productive cough, also chest tightness, can cause dyspnea, and it's all related to the occupational exposure. So that's one of the things that you need to ask your patient in order to find or rule out this differential. And of course, the CT scan will be kind of different, that it will show centrolobular micronodules, and it can show mated as well mediastinal lymphoadenopathy. So that's one of the cases that you could probably see in the clinical setting, and what what you can see. Sarcoidosis in the UK, I said it's common. As I come across some cases I've seen, but it couldn't be that common sometimes. It's as I say, it's granulomatous, a tiny cluster of those inflammatory cells in organs like lung, skin, eyes, and can have a genetic element. It affects 1 in 10,000 people in the UK. However, it says that 3,000 to 4,000 new cases are diagnosed annually. So I don't know if that's considered common or uncommon. However, it can be manifested in young people around 20 to 40. I remember one case when I was doing in Salford Hospital. I've seen a case who was presented with multiple nodules all over her body externally. And the first differential being given is sarcoidosis, and it was sarcoidosis. Another case I remember seeing, it was a man who had sarcoidosis in his lung and in his skin. So, so as I say, I don't know if the figure, it could be. It could be uncommon and not that common, but it's still a case that can be seen here in the UK or anywhere. And as I say, genetically, it's one of the cases, and environmental causes or occupational exposure implemented in the causation of sarcoidosis. Thank you.